Assalamu alaikum. Good morning, everybody. My name is Mohammad Aljenfawi. I'm a cardiology fellow from King Fahd Cardiac Center. Today we're going to talk about TAV and Stentless SAV. So our patient is a 76-year-old gentleman. He had hypertension, atrial fibrillation, dyslipidemia. He had a stage 3 CKD. He had previous history of CABG with Lima to LAD. He had a surgical aortic valve placement using freestyle valve 2013. He had a permanent pacemaker 2024. The patient presented to us with very severe symptomatic degenerative aortic valve hyperemesis with aortic regurgitation, complicated by recurrent heart failure. And he was deemed not fit for redo surgery or TAV at outside hospital, and he was planned as a case for palliative treatment. So this is the echo for the patient, paracentral long axis. We can see that there's severe aortic regurgitation. This is the surgical valve. You can see the severe aortic regurgitation here again. We can see the ejection fraction. It's about 25%. Here we can see the jet for the aortic regurgitation. It's central. It's not paravalvular. Okay, so we proceeded with cath for the patient. We're checking the left system. We can see a patent. Let's play. We can see a patent left main, left anterior descending is patent. Here the circ, it's patent. We have a moderate lesion, the proximal left circumflex, it's dominant. And you can see there is no obvious valve. We don't see calcification, we don't see the previous valve. Here we can see also a patent Lima to LAD. This was the surgical freestyle valve used. It's rarely used. It has no stent around it, no ring, so no support. However, it has a big orifice to accommodate people with smaller annulus to avoid annular dilatation surgery and improve sometimes the LV hemodynamics afterwards. So we can see in the sinus height, it's about, for the left coronary artery, it's about 8 millimeter, which is small or short. It increases the risk for obstruction if we did the TAV. For the right coronary, it's a little bit higher, however, it was non-dominant. This is a virtual simulation. We can see the distance between the virtual valve to the left coronary artery. It's about 3.7, a little bit more than 3. It gives a lower risk of obstruction. To the right coronary artery, it's less than 3, which is a higher risk of obstruction. However, also it's non-dominant, focusing on that. This is the simulation. We can see that there is some distance between the valve and the left main, and so we thought that this distance is enough to avoid obstruction. You can see the right here. Sinus of valve diameter, it was less than 30, it was about 26, also increasing the complexity of the procedure and the risk of obstruction. Here, the ascending aorta, we can see there is a lack of calcification. Another image here, we can see that there is a lack of a calcification, which is gives us a technical difficulty how to anchor the valve and to prevent migration of the valve itself. So we went ahead and examined the iliofemoral arteries. Both of them were sufficient with the diameter more than 5.5 with no access, with no complication. So what are the challenges of the Stentless valve? So this valve has no stent, so it has no fluoroscopic markers. There are a variety of surgical techniques with the freestyle valve, so basically we don't know where exactly is the valve. The main mechanism of the failure of this valve is aortic regurgitation, which makes it very difficult for inserting the valve, leading to increased risk of migration of the prostatic valve. Also, there is a risk of coronary obstruction due to the VTC area less than 3 millimeter, which increases the high risk of obstruction. However, as we said, that the patient was deemed palliative. However, he had no quality of life. Repeated admissions to the hospital, he was not able to discharge, and he accepted the high-risk procedures. This is the valve itself. You can see the mesh here. There is no support. Okay, so strategic planning. So we planned to protect the LAD. It was protected with Lima. The left circuit was dominant, so we planned to insert a wire stent, keep it there in case of obstruction. how to know exactly where is the valve. We were going to use a balloon to know where exactly is the annulus. And we wanted to inflate it slowly to avoid for the valve migration later on. So starting with the procedure, you can see proper puncture with no access complication. Aortogram here, you can see the obvious severe aortic regurgitation. Also, you can see that there is no calcification. Another image here showing exactly the... So, to the procedure, we can see that we put a guide wire, we put a stent and lift the circ to protect it in case of obstruction. This pigtail was the anchor point to show it where is the annulus of the previous valve. You can see we are inflating slowly. You can see the valve is inserted deeply than usual. Here, thankfully, there was no obstruction after planting the valve. You see now there is a proper placement of the valve with no paravalvular leak. There is no regurgitation. This was basically what we have done. We inserted it here. You can see it, again, another view. There was no leak and there was proper positioning. So finally, I would recommend to read this case report. It tackles deeply the previous challenges we have seen before, or we have faced. Thank you so much.